Good evening, one and all, dear friends, dear young intensivists, dear colleagues. Today's critical case Sunday webinar is a case-based discussion that we have monthly. So, presentation is from the Department of Anesthesiology, Critical Care and Pain, All India Institute of Medical Sciences, New Delhi. The case is one of fever and MODS, something we encounter very commonly. It will be presented by Dr. Shashikant. So Dr. Shashikant is a third-year DM fellow at the institute and moderated by Dr. Rahul Kumar Anand sir. Sir is additional prof there. And along with us, we have senior consultant Dr. Ritesh Agarwal. He's at Max Specialty Hospital, New Delhi. So over to you, Dr. Shashikant. Please share your screen.
Sure, sir. Is it visible? My screen is visible.
Yes, please start.
Slides are moving, sir?
Yes.
Okay, sir. So, shall I start, sir?
Yes, please.
Good evening to all. So today's case is of fever with MODS. Myself, Dr. Shashikant. I'll be presenting the case scenario here. So we have a 29-year-old male, a resident of Shahjahanpur, Uttar Pradesh, shopkeeper by occupation, 12th pass. History was given by his brother-in-law and reliability is good. So patient presented to emergency department of AIIMS on 17th of November this year with chief complaints of fever on and off for last 10 days, bleeding manifestations for last 6 days, cough for last 4 days, swelling all over the body for last 4 days, and altered sensorium for last 2 to 3 days. So patient was apparently doing well till 8th of November when he started having fever, which was documented up to 103 to 104 degree Fahrenheit. It was intermittent. There was no systemic localization, no rash, arthralgia or myalgia. Fever used to be relieved partially with oral antibiotics, and patient became febrile after 5 days of onset of illness. Patient started having bleeding manifestation in terms of bleeding from gums, 1 to 2 episodes per day, and he had also one episode of bleeding per rectum, which was mild in amount as per the history. Patient started having cough for last 4 days, which was dry in nature. It was not associated with any chest pain, difficulty in breathing, hemoptysis. There is no history of palpitation, orthopnea, paroxysmal nocturnal dyspnea, or pedal edema. Patient also reported to have swelling all over the body for last 4 days, and there is no history of jaundice or decreased urine output. He has started having altered sensorium and altered behavior for last 2 to 3 days. There is no history of fever at this point of time, no history of headache, nausea, vomiting or seizure, and no history of focal neurological deficit.
So, what is the summary of the history, Dr. Shashikant? Have you summarized it?
So the patient who has presented with fever.
We can go back to the first slide just to see the history and examination.
Yeah, so we have a 29-year-old male with no prior comorbidities. He presented with fever on and off.
Yeah, okay. So now this patient has fever, bleeding, cough, swelling over the body. You said there is no pedal edema. So how do you qualify this swelling over the body? What does it actually mean?
He was having swelling over the face and over the upper extremity, sir, but not reportedly on the lower limb, sir.
So was there any edema on the pitting edema anywhere on the upper arms, or just it seems swollen?
It seems swollen, sir. He was having like facial edema predominantly. Okay. It was just reported to have edema over the upper limbs.
Okay, okay. So if one wants to just look at the symptom complex, he has fever, he has cough. So fever can be because of sepsis, can be because of tropical infection, can be because of many reasons. Then cough can come from the respiratory system. Sometimes cardiogenic pulmonary edema gives rise to cough. Swelling over the body can be because of renal involvement. There is shutdown, renal shutdown. There can be CHF, but CHF usually will have pedal edema. so that is not there, or can be because of chronic liver disease. And sometimes they can be just oozing of fluid because of hypoalbuminemia or leakage of the vascular capillaries. And altered sensorium, the commonest causes of altered sensorium coming to the ICU is stroke, septic encephalopathy, or metabolic encephalopathy. So if you look at all these, this could mean either the patient is in sepsis, there could be a tropical infection, or there could be multi-system disease. So that is the broad differential of the symptoms. So let us move on then. Bleeding manifestations, of course, can be because of some kind of DIC, or can be because of chronic liver disease. We have to see why the patient is bleeding. Bleeding is a manifestation of normally DIC or chronic liver disease. So let us see. Please carry on.
There is no significant past history for this given patient. Family history is not significant. Coming to the personal history, the patient consumes a mixed diet. There is no history of addiction with normal sleep and appetite and normal bowel and bladder habit. So coming to the treatment history, patient got admitted in a local private hospital from 10th to 14th of November. During that stay, the serial blood counts showed thrombocytopenia and leukopenia, and he was found to be dengue NS1 antigen and IgM positive. Apart from it, other details of treatment and medications were not available. Again, on 15th and 16th, he got admitted for 1 day into another local hospitals, and their investigation showed improving thrombocytopenia. However, he was found to have elevated SGOT, direct hyperbilirubinemia, and non-oliguric AKI. He received ceftriaxone, amikacin, and nebulized bronchodilators.
So, Dr. Shashikant, you have mentioned elevated SGOT. So what is SGPT?
Sir, actually, the reports we had, it had just mentioned the SGOT value, not the SGPT.
Okay.
So it was around 1700, sir. SGOT value was 1700.
And you have mentioned non-oliguric AKI. So, is it different from oliguric AKI in any way? The connotation that non-oliguric and oliguric?
Sir, actually, exactly the amount of urine he produced in 24 hours, it was not mentioned in the records. But
no, that is fine.
Yes,
but does it have any bearing on the outcome or on the prognosis, non-oliguric AKI and oliguric AKI?
I'm not very sure, sir, whether this makes a difference in long-term renal parameters.
So I will. So oliguric AKI is actually worse than non-oliguric AKI. It has been seen patients who have non-oliguric AKI have a better prognosis. So that is not entirely clear, but it is believed that non-oliguric AKI for the same creatinine, like you have two patients, one is oliguric AKI and one is non-oliguric, they have the same creatinine. Non-oliguric AKI, the renal injury is less. So they have a better prognosis, and also due to the fact that they are passing urine. So the volume overload is less, the acidosis is less, the hyperkalemia is less. So non-oliguric AKI has a better prognosis than oliguric AKI for the same creatinine. The other thing is he has received ceftriaxone and amikacin. So can you give amikacin in AKI?
Ideally, we should avoid because it has nephrotoxic potential. So we should not cause further renal injury when we have a compromised renal function.
If you have to give, there's no option. The culture sensitivity is given. Can you give at all, or you cannot give at all?
We can still give with reduced dose and modifying the dose as per the creat clearance.
Very good. So you can give if there's no option, you should avoid. But if you have to give, then amikacin can be given in modified doses in AKI. And is there any relationship between ceftriaxone and LFT?
Ceftriaxone, yes, sir, definitely, because it is excreted to biliary route. So if the patient has deranged renal parameters, especially hyperbilirubinemia and some obstructive pattern of liver injury, we should avoid giving ceftriaxone.
It is not like that you have to avoid giving ceftriaxone in LFT, but if the deranged LFT, but ceftriaxone can cause alteration in LFT. That is the thing, because it, like you rightly said, that it has to be avoided. It causes altered LFT. So the SGOT may be coming from ceftriaxone. We have to see, but there's a direct hyperbilirubinemia. Normally, it does not cause so much hyperbilirubinemia, but definitely altered LFT can be seen with ceftriaxone. Okay, please carry on.
So he was brought to us on 17th of November. So on evaluation, he was found to be afebrile. He had GCS was full, but he was a bit drowsy and he was ectric on presentation. His BP was 140 by 90 millimeter of mercury, pulse rate of 88 per minute. His respiratory rate was 22 per minute, and he was saturating to 98% with non-rebreathing mask with 8 liters of oxygen. His CVS was unremarkable, and respiratory examination showed bilateral equal air entry with basal clefts bilaterally. His abdomen was distended, however, it was soft and non-tender.
So, what is the cause of drowsiness according to Dr. Shashikant?
So, here possibility could be, sir, the patient with probably he has first differential is my tropical illness with multi-system involvement. So the tropical illness like dengue, leptospira, scrub, and even the typhoid fever.
You have said the IgM is positive and NS1 is positive.
Yes, sir. So here in this case, it is dengue encephalopathy will be first possibility. It is the possibility. This is the cause, dengue encephalopathy. Right.
Any other differential you have?
Apart from it, patient is having swelling all over the body and he's having AKI. So metabolic is another, uremic encephalopathy will be another possibility. We need to look at the electrolytes. So dyselectrolytemia in terms of like hypo or hypernatremia will be another possibility.
Yes, so metabolic encephalopathy has deranged the kidney function, like you said. We have to see the values, and also jaundice is there, can be hepatic also.
Hepatic encephalopathy.
So what is against the diagnosis of dengue encephalitis here? Drowsiness has just come, right?
Drowsiness, yes, sir.
Yes, he has just become drowsy and he has come to you after 10 days.
Yes, sir.
So what is the usual course of dengue? Do you know the usual course of dengue?
Yes, sir.
What is the usual? There's initial phase, then there's a critical phase, and there's a recovery phase.
The initial first 3 to 4 days will be the febrile phase. Then we have the critical phase that may last for another 3 to 6 or 7 days. Then we have the recovery phase after that.
Yeah, so he's past that period, right? He's come out to you after 10 days.
Yes, sir.
So dengue encephalitis, a remote possibility, cannot rule it out, but because he has come to you so late and he's only become drowsy now, it is unlikely he's going to be dengue encephalitis. Most likely, this is a metabolic encephalopathy, and sometimes, stroke can occur because of various reasons. You never know. Though he's a young patient, but you have said there's no focal neurological deficit. So unlikely. Always think of stroke because stroke is the commonest cause of altered sensorium coming to the ICU. However, a dengue patient is unlikely to have stroke and is a young patient. So metabolic encephalopathy would be the most likely possibility here. Please, and the blood pressure is good, 140 by 90. So pulse rate is also good. So let us see now what is going on. And oxygenation is also not that bad. So what we have is there is some jaundice, there is some renal dysfunction, and there is altered sensorium with normal hemodynamics. Please carry on.
Shashikant, I think you mentioned that drowsiness was there for last 3-4 days. No. It was there, I think.
Yes, sir. In background, it was for last 2 to 3 days. It was there, sir, before the patient came to us.
Okay.
So anyone, please, Dr. Rahul sir and Dr. Ritesh sir, if you have any comments, please carry on as you want to make. Carry on.
So I think sorry, Shashikant.
Yeah.
In this patient, this drowsiness may be because of sepsis per se, because he got admitted to many hospitals. It may be some hospital-acquired infection also. It may be some encephalopathy or some metabolic encephalopathy, like septic encephalopathy or metabolic encephalopathy. So we have to rule them out.
Carry on, Dr. Shashikant.
So during the course of stay in the emergency department, the patient became more drowsier. He became like from initial full GCS to E4, B4, M5. And he also started having worsening oxygenation and respiratory distress, for which he got intubated. So the point of care testing showed IVC was kissing, so patient was volume depleted, but we and lung showed bilateral threats with anterior B profile. So there's suggestive of some component of infection and along with fluid overload. 2D echo was normal. There was no pericardial effusion, and ultrasound abdomen showed minimal free fluid in the hepatorenal pouch, and there was coarse echo texture of liver with mild splenomegaly.
Sorry, I'm interrupting.
Yes,
Interrupting you,
please,
Shashikant.
Doctor.
So, like IVC is kissing and lung is suggestive of some basal shreds with anterior B profile. So, this may be because of the leaky capillary phenomena. Patient is accumulating blood fluid in the lungs. Please carry.
That is one thing. The other thing is, first, why he has become. How long did he stay in the emergency department, Dr. Shashikant?
Almost, sir, 16 to 18 hours he was there.
So why do you think he has become intubated and become more drowsy? Why he become intubated? He can become more drowsy or whatever underlying process he has, but why has he got intubated? He had hardly any oxygen requirement.
Initially was on NRBM, but later on, what as per the ED records, he was put on HFNC for some time, and they mentioned the PF ratio of less than 150. But exact respiratory distress they have not described in the records, sir.
So did he
So
get
what
fluids
actually
in the
happened?
ED? He did, because IVC was kissing, have they given a lot of fluids?
I mean, like they have given fluids, but exact records
Yeah,
and
okay.
along with intake output monitoring was not there in the records.
So, Dr. Ritesh, any comments on why he got intubated? He hardly had any oxygen requirement, and within 16 hours he's got intubated.
I think he got tubed because of respiratory distress. Probably he got fluids over there. When they assessed him for volume, they found him hypovolemic. What were the hemodynamics, by the way, on arrival to ER?
It was, sir, initially the mention I just mentioned here. It was 140 by 90 and pulse rate of 88, sir. At this point of time,
He was already
Please
yeah.
carry on.
Yeah, he was already on NRBM on arrival, and then he progressively worsened with respect to respiratory failure. And what is your inference, Dr. Shashikant? You feel he received a lot of fluid or not?
sir, most of the ED patients they receive almost like 100 ml per hour of fluid. So by this time, he must have received more than 2 liters of fluid.
So that is probably the likely cause. He has dengue. Dengue have leaky capillaries. He has received a lot of fluids, the IVC kissing, and it has gone into the lungs. That is one possibility. Any other possibility, Dr. Shashikant?
Other possibility, this patient is having basal threads. So whether he had got some hospital-acquired pneumonia because he had multiple
that will
hospitals.
not progress so rapidly that will get intubated.
Another would be a patient having encephalopathy, and by that time, whether the patient started having hypoventilation and was having type 2 respiratory failure. Along with that, hypoventilation was too severe to cause type 1 respiratory failure.
So was there any ABG in the
unlikely.
ICU? Is there any ABG in the ER?
We had one or two, sir. Actually, I think I have missed that ABG.
That's all right. So other reason is he could have airway obstruction. He's drowsy. That is one thing that he started retaining secretions. He's drowsy. And
maybe
it is possible, but I don't think he's that drowsy. He was M6 when he came, and he become M5. A little bit drop is there. So I don't think he would have gone into hypoventilation. So like most likely he received a lot of fluids. Second is there could be airway obstruction because his sensorium is dipping a little. The other thing is about IVC kissing. Okay. Now the IVC is kissing means it's grossly hypovolemic. He is a spontaneously breathing patient. I believe this was done without the ventilator. And his blood pressure is 140 by 90, right?
Yes, sir.
So 140 by 90 means there's a very good stroke volume.
Yes, sir.
Stroke volume, that means you cannot be that much volume depleted. Agreed?
Yes, sir.
So IVC is kissing and the stroke blood pressure is 140 by 90. These things too don't correlate that well. So
yes, sir.
And he's in renal failure, so he must be retaining fluids also. So what could have probably led to IVC kissing with a normovolemia? The pulse pressure, if the blood pressure is correct, which we assume 140 by 90, he cannot be hypovolemic, that much hypovolemic. So why IVC could have been kissing?
So this IVC assessment depends upon cardiopulmonary interactions, sir. So if the patient's respiratory drive is too much, so again,
Very
because
good.
of this.
Absolutely. So that is what is happening. He's probably hyperventilating. And the fluid is so much that the IVC is kissing. And that is why, now all as you may know, the papers all say that in a spontaneously breathing patient, the IVC assessment is not really that good. You cannot rely on it. Your blood pressure is in front of you, 140 by 90 is unlikely to be there with a hypovolemic patient. The pulse pressure will become so his probably respiratory drive is quite increased because of maybe drowsiness or what the lung involvement or whatever. Okay, very good. And the other thing is There are no pleural effusions noted. There is some ascites. So now you have said this is dengue and he's having multi-organ involvement. What is unusual in this patient on ultrasonic examination? Is there anything he's got severe dengue, right?
Actually, so I expect serositis in lungs also, and also around
Very
the
good.
heart.
Absolutely. So, in a patient with dengue who has severe dengue, so severe dengue is classified as any patient who has organ failure. So he has 3 organs involvement. So definitely this is severe dengue. It is very rare to have severe dengue without pleural effusions and ascites. There is some ascites, though it is minimal, and there is always pleural effusion almost. Only 5% of the patients with severe dengue do not have pleural effusions or ascites. It is very rare. So when I have missed the pleural effusion, which I doubt, this is unusual not to have pleural effusions. The thing is, what else do you get on ultrasound which helps, See, the diagnosis of dengue depends on IgM and NS1, and that depends on the kind of kit you are using. The kind of kit that you are using varies in different labs, and sometimes it is not best. We often get dengue negative even if IgM negative, even if dengue is positive in some of the ICUs. So is there any diagnostic test on ultrasound which can help apart from ascites and pleural effusion? It is an early sign.
Sir, if we have GB wall edema,
absolutely, very good, very, very good. So GB wall edema you always have. This is my experience, and this is noted also, and it occurs because of serositis or hepatitis. This is a very early sign. You do ultrasound and GB wall edema will be there. It comes even before the IgM report because you can always get ultrasound done immediately. So, Doctor, you want to say something?
Yeah. So I just want to highlight one point about the IVC. One thing, as you said, that the reliability is there if the patient is on mechanical ventilation, not the spontaneous breathing. The second thing is that guidance of fluid after looking at IVC should be done if the patient is hypotensive. So if you are not hypotensive, then whether it is kissing or not kissing, that doesn't directly mean that you give fluids to the patient. So this patient was hemodynamically stable. If the IVC is kissing, it's okay. That doesn't mean that we start rushing fluids for this.
Yes.
Hello.
Yes, Dr. Ritesh.
Yeah,
you are saying exactly.
So, was I audible or should I?
You are audible in between. Please just.
Okay. So what I was saying is that the inference from kissing IVC has to be taken with respect to whether the patient is hypotensive or not. If the patient is not hypotensive, even if the IVC is kissing, that doesn't translate into requirement of fluid boluses or fluid resuscitation.
Yes, absolutely. So what you are trying to say is that even if the patient is showing fluid deficit, only if he requires fluid, should be fluids be given if there is evidence of hypoperfusion. Absolutely.
Yes, yes.
So, Dr. Rahul, any comments or should we move on?
We can move on.
Carry on, Dr. Shashikant.
So, initial investigation, the CBC showed thrombocytopenia. He was having deranged renal parameters with urea of 356 creat of more than 11. His SGOT and SGPT both are elevated. SGOT was more than the SGPT, and he was having direct hyperbilirubinemia, and INR was around 1.55.
So here, Dr. Shashikant, your TLC has gone up.
It is just borderline, sir. It is
no. This is significant. He was leukopenic, and now he's 12,000.
Yes, sir. So initially he was leukopenic when he was evaluated in the first hospital, but now it has increased.
And it is very interesting to note that did he have bleeding manifestations when he came to the ER?
He was having some bleeding from oral cavity and also from the nostrils, sir. It was minimal bleed.
So with a platelet count of 60,000 and an INR of 1.5, that is not so common even if you have dengue, right? So this is slightly unusual that he's having bleeding. The other thing is TLC has gone up. Definitely this is a problem, and one of the foremost things here would be an infection. A secondary infection has We have
Yes,
to,
sir.
because leukopenia to 12,000 is very significant. So this is possible that he's got a secondary infection developing, or if he has received steroids. Has he received steroids? We do not know. They have to given him steroids outside, so that can also cause to an elevation of TLC, because people give steroids in dengue sometimes outside. It is not recommended at all, but sometimes they do give. So that is the other thing. We do not have the treatment history in detail. And the other thing is bleeding is slightly unusual, though dengue patients can bleed, but normally in a patient who has a count of more than 50,000 and an INR of 1.5, you would not expect bleeding. Maybe there's something else also leading to bleeding.
He is severely uremic also.
Yes. Maybe
So
because of uremia.
Yes, so that
So
is one of the reasons why he's probably
Encephalopathy.
uremia leads to platelet dysfunction, and like Dr. Ritesh has very correctly pointed,
exactly.
is severely uremic. This is very high urea creatinine. So platelet dysfunction is occurring because of uremia, which is probably the more important factor. And of course, dengue patients not only have thrombocytopenia, they also have platelet dysfunction. What is the cause of the coagulopathy? You have low platelets, you have altered PT, INR, APTT. So all this occurs because of a complex coagulation disorder, and it is not DIC in dengue. And there is always platelet dysfunction also, not only thrombocytopenia. It would be very interesting to note the APTT, Dr. Shashikant. You have not mentioned APTT.
Sir, I've just mentioned in the summary of investigation, sir.
So what is the APTT here?
Sir, on admission, it was like 32 to 34 only.
So there is hardly any derangement. There is no.
Yes, sir.
Yes.
This is a lot of uremia and some degree of dengue here, which is leading to bleeding. Please carry on.
So this uremia itself explains why the patient is drowsy. With such a high urea, patient has to be drowsy. Yes.
Absolutely, I agree with you. This is probably uremic encephalopathy, and also I have to look at the ammonia levels. Because sometimes dengue patients have gone into acute liver failure also. So ammonia levels would be important. Was the ammonia level done?
No, sir, we could not do it because of the laboratory issues.
Okay.
These days we
So
are having.
you cannot rule out altogether. There is significant SGOT-PT, bilirubin rise, and INR is more than 1.5. So liver also has to be taken into consideration. But the foremost cause, like Dr. Rahul sir said, is uremic encephalopathy here. Dengue encephalitis, the small possibility is there, but normally too much time has elapsed for dengue encephalitis to occur. The complications would normally occur earlier of dengue encephalitis. Carry on, Dr. Shashikant sir.
From ED itself, patient was started on broad spectrum antibiotics, NAC infusion for elevated liver enzymes, and after that he was shifted to our ICU for further management. So,
Dr. Ritesh sir, is the NAC infusion justified here? What is the evidence? We give NAC infusion when there's significant derangement. What is the evidence say for NAC infusions? Ritesh?
So the evidence for NAC initially started only for acute liver failure, but then it is now being extrapolated that if there is a significant liver injury, then N-acetylcysteine may have some benefit. So it is still may have some benefit and no harm.
Yes.
So is this justified in the absence of acute liver failure? I think it is only acute liver failure with stage 3, stage 4 hepatic encephalopathy or paracetamol injury, any kind of paracetamol injury, but not in any derangement of LFT. Dr. Rahul sir, your comments on evidence infusion.
As Dr. Ritesh was saying that it has got very low side effects or toxicity symptoms. So any kind of liver dysfunction, when we are suspecting that liver injury is ongoing and may increase, so it can be given as a prophylactic, okay, to prevent, or that's the only thing. So if you talk about the evidences are there in poisoning, like paracetamol poisoning. It is also there in some ischemic hepatitis patient, but as such, literature is not so strong.
Yes, so there is no clear-cut evidence to support without acute liver failure or paracetamol poisoning. And acute liver failure also stage 3, stage 4 hepatic encephalopathy. Rest, there is no harm. That is what has been seen, but there is no evidence to support it. Does not result in better outcomes. That is the evidence for NAC infusions. We use it all the time because no harm has been shown, but there is no benefit either. And harm can always be there. We do not know, but that is the evidence for NAC infusion. Carry on.
Summarize, we have a 24-year-old male with no prior comorbidities, with prodrome of symptoms, and on NS1 and IgM positive. So my impression is severe dengue with multiple organ dysfunction with AKI and ALF.
Yeah, one sec. Just go back to Dr. Shashikant. You have used ALF. Is he in ALF?
There is encephalopathic. His INR is just borderline. It's more than 1.5. So, and he's having jaundice.
No, but encephalopathy, how do you qualify the encephalopathy as hepatic encephalopathy without ammonia? And in the presence of uremic encephalopathy and possible dengue encephalitis, can you say that the encephalopathy is hepatic encephalopathy?
Clearly, I cannot say it is just because of liver. Patient is having multiple things to.
You should say acute hepatitis. The word should be used acute hepatitis.
Acute hepatitis.
Carry on.
When patient came to ICU, he was afebrile, and that point of time I was sedated with fentanyl around 50 mics per hour. His pupils were bilaterally equal, 2 mm in size and reacting to light. His BP was 146 by 78 millimeter of mercury, heart rate of 118, and his saturation was 98% on volume control mode of ventilation with FiO2 of around 40%. His cardiovascular examination was within normal limits. Respiratory system showed equal bilateral entry with bilateral basal creps, and per abdomen examination was similar to what he was having in ED.
So, any comments on the people? Just stay there. Any comments, Dr. Ritesh, on the pupils?
Pupils, he's saying is 2 mm and reacting.
Yeah, so it is towards constriction side. So one is he's on fentanyl. So fentanyl can cause, if it has any other reason for small pupils here, this is extremely small.
As such, they are not extremely small. 2 millimeter for a patient who is in ICU, sedative, well sedative with fentanyl, it is quite common, isn't it?
Yes, so fentanyl is one reason, but depending on how long the fentanyl is going on, the other thing I was just trying to highlight is metabolic encephalopathy. Patients with metabolic encephalopathy can have small pupils. So anything 2.5 would be small. So this is small. Metabolic encephalopathy is a differential for small reactive pupils. Now, a very interesting thing is the blood pressure. You see any comments on the blood pressure from anybody? It is the pulse pressure has widened. You know, it is 140 by 80. So that is a pressure of 65. So that is a widening of pulse pressure is occurring here. You know, the pulse pressure has changed. It was 145 by 90. So if it is correct, there is the pulse pressure has widened. That means the SVR is decreasing to some extent, or the stroke volume is increasing, or he is going into some degree of vasodilatation here. So is there sepsis setting in here? The blood, this is not a normal blood pressure, 145 by 80. Anything more than 60 is the wide pulse pressure. And wide pulse pressure can be because of increasing stroke volume or can be because of decreasing SVR. So there is a slight change in the blood pressure here. And if there is a decrease in SVR, one has to think of sepsis setting in because, the TLC is also...
Acidosis, metabolic acidosis.
Metabolic acidosis, the situation is not like that for metabolic acidosis. Normally, there'll be, if there is a SVR is decreasing, then there'll be myocardial depression also with acidosis. It is not, commensurate with metabolic acidosis, I think. Like with sepsis-induced vasodilatation, because you have...
Most likely.
Yeah, TLC
it's because of sepsis.
Yeah.
And some component may be because of fentanyl per se. Some small vasodilation.
Yes, absolutely. Fentanyl can also decrease the SVR. Some vasodilatation occurs. Fentanyl is another possible also. Yes. Please carry on.
Initial point of care ultrasound shows bilateral.
So my question is, he was kept only on fentanyl sedation? There was no benzodiazepines on board?
No, sir. He was not on any benzodiazepines.
So my question to that is then, so you were accepting that there is a liver injury, you didn't have ammonia at hand, and you were probably thinking of protecting brain like that?
No, I would like to answer this. We, as a protocol, we don't give benzodiazepine. If patient is not well sedated on fentanyl, then we start Dexmet or propofol. We as such, is our institute policy, we don't start benzodiazepine partly because it is associated with certain poor outcomes. And we have seen lots of delirium, hyperactive, but especially hyperactive delirium with benzodiazepines. Okay.
I agree absolutely, Dr. Kumar. According to the latest PATIS guidelines published a few years ago, benzodiazepines are not advocated. Either you use fentanyl, or you use propofol, or you use dexmedetomidine. Benzodiazepines lead to increased ICU stay, lead to increased delirium, and increased post-intensive care syndrome. So the two clear-cut indications for benzodiazepine infusion is status epilepticus or alcohol withdrawal syndrome. Intermittently, you may use it if you require, but definitely long-term infusions on ventilator should be avoided. So I agree with that. Next slide, Dr. Shashikant.
Yes, sir. So our initial point of care ultrasound testing showed lung having bilateral basal consolidation, which was static air bronchogram with right minimal site pleural effusion. 2D was perfectly normal. IVC was around 1.1 centimeter with minimal variation, and DVT scan was negative. So we continued on the broader spectrum antibiotics, which was started in the ED. It was meropenem, ticoplanin, and we continued the NAC infusion as of now.
Sorry, Dr. Shashikant, I'm interrupting you now. So now the IVC, the variation are minimum. So it may be because like previously it was TC. So it may be because of metabolic acidemia. Okay, now patient is on mechanical ventilation and because of the better control of respiration. So this variation is not there. Maybe because of that.
Yes, I agree, Dr. Rahul. The other thing is, the pleural swing has been obliterated. Now it's on controlled ventilation. So
Yes.
ml per kg. So that respiratory variation has gone because of the intense pleural swings which he was probably generating. And he has received
Acidemia.
2 liters of fluid also. So all that has gone. So that is why IVC on the ventilator can be taken as a sign of hypovolemia or hypervolemia. That is the difference that you can see the marked difference. But he has received fluids in the eyes in the ER. The other thing is, I would just like to ask you, ticoplanin has been started, Dr. Shashikant. So do you see a lot of staff in your ICUs or in AIIMS ER or ICU that ticoplanin has been started? Do you get culture?
It's not very common, sir. I think it's one of kind of rare bug to see in our ICU.
Yes, it is a rare bug to be seen anywhere in our country. So this is a very strong distinction between our country and the West. Commonest bug in the ICUs is Staph aureus, but in our gram-positive other organisms. In our country, we are predominantly gram-negative, and it is a tendency for all of us to start ticoplanin just to give broad spectrum coverage. If you read the sepsis 4 guidelines published last year, they have made a clear statement that unless there is a strong risk factor for starting MRSA cover, you should not start, and it actually leads to worse outcomes. So this is a very important thing. We all have this habit of starting ticoplanin and meropenem, and we do not have staph in our ICUs. Staph has very specific risk factors. So can you name some risk factors for staph infection, Dr. Shashikant?
Patients who are having invasive lines, like in terms of having tunneled CVC, those who are receiving care in the nursing homes, those who are having some soft tissue infection, or if there is some MRSA colonization. So these are the risk factors for having MRSA.
Yes,
post-viral is a group which has a tendency to get gram-positive and staph infections. TB and dialysis. So these are other group of patients. Moreover, this patient was having low platelets count, so probably ticoplanin should have been avoided.
I have a comment here. Say if the thrombocytopenia is because of sepsis and that sepsis is because of staph, then there is no harm in giving ticoplanin. It's going to take care of that. And ticoplanin will lead to thrombocytopenia after 6-7 days of therapy, usually. But regarding ticoplanin, or we can say regarding staph infection, I want to add one thing here. Like these organisms, they are relatively delicate organisms. If we take the endotracheal aspirate sample and keep it there for 2 hours, it's not going to grow. So if you take the sample, you have to send it immediately to the lab. That should be mounted within 2 hours. Otherwise, we always have some negative result. That's also one issue with these gram-positive organisms.
Yeah, I agree with the thrombocytopenia. So, Dr. Ritesh, I just like to differ. If a drug is most of the antibiotics, beta-lactam and all these antibiotics can cause thrombocytopenia. So you cannot say like if there is thrombocytopenia, you should not give this antibiotic because the incidence is very low. And if sepsis is causing the thrombocytopenia, it will be corrected by that antibiotic. So I'd like to differ from you on that account. But at the same time, about gram-positive infections, Dr. Rao sir, I just like to say that staph grows very well also in cultures. Within 24 hours, if staph is there, of course, it has to be processed rapidly and properly. That is true for all cultures. But if it is there, especially in the bloodstream, it grows within 24 hours. And I think for other cultures also. And you cannot, I think you will agree that we do not get staph, right? We get the other cultures positive, but the staph overall is very low in our.
Yes,
So
it is
just
very common. Very
yes,
uncommon, sorry.
yes, yes.
What I was trying to say is, like, in the endotracheal aspirate, if we keep what happened, like if we take the sample at 6 a.m. and we send our GD to the lab, and the lab people will mount it at 10, the chances of getting positive result will decrease in the gram-positive infections very rapidly if it is more than 2 hours. So for the gram-positive, if one is suspecting gram-positive infection, one has to shift the samples very fast so that it can be mounted within 2 hours. Okay, if we delay the mounting time, the chances of getting false negative result is really very high.
Okay, I think that may be true. I do not know about the mounting time, sir. Thank you for that comment. Okay, carry on, Dr. Shashikant.
On day of ICU stay, on assessment, his GCS was E3-BT-M6. He was afebrile. His BP was
So
hovering
sensorium
between.
has improved, huh? He's become M6. He's become E3 and M6.
Yes, sir.
Huh?
Yes, sir. He was in ED. He was like E4, V4, M6, sir. So it was kind of same only as of now.
Okay.
M is 6 and is E3. His BP was ranging between systolic 132 to 148, diastolic between 65 to 80, with heart rate of 85 to 100 per minute. He was continued on control mode of mechanical ventilation with FI out of 40% and PF ratio was above 300. However, he was having low urine output around 15 to 25 ml per hour and received one session of SD for uremia and low urine output. We started him on enteral feed and we withhold the DBT, pharmacological DBT prophylaxis because of thrombocytopenia was having oral bleed. And we sent cultures from endotracheal secretion, blood and urine.
So, this DVT prophylaxis, was he getting some kind of DVT before he arrived in the ICU or something?
No, sir. Before coming to us, because as per previous records, it is not mentioned whether he was given some DVT prophylaxis or not, because those records were not mentioning any kind of like UFH of or LMWH.
So there is no record of receiving anything, right?
Yes,
renal failure, huh?
Yes.
Okay. So he started on dialysis as soon as he comes.
No, sir, it was not immediately. Yes, he came to us in late midnight, sir, around 3 a.m. And he received the dialysis in the daytime, sir.
Okay, please go ahead.
Yes. So on day 2, he was found to be like E3-BT-M5, still was afebrile, and BP was 126 to 145, diastolic between 62 to 78, heart rate of 80 to 60, 80 to 96. Still continued control mode of mechanical ventilation with good oxygenation. However, urine output continued to decrease to like 20-25 ml per hour. On the same day, around 3 p.m., we noted he was having high BP records, systolic ranging between 170 to 195, diastolic 100 to 110, and he was having bradycardia.
So
this, yes, sir.
Okay. So, Dr. Ritesh sir, what is happening at 3 p.m.? Any comments?
Yeah. Some catastrophe has happened now. Most likely brain. He's gone into sudden surge of hypertension and associated with a bradycardia. So
what is there any particular name given to this kind of a phenomena?
So he's in Cushing.
Cushing reflex.
Yeah.
Cushing reflex.
Yes. So this is he's gone into Cushing reflex, which is supposed to occur because of sudden surge in brainstem compression because of raised ICT, and that is characterized by high blood pressure, bradycardia, and irregular respirations. So this is a sign of medullary compression or brainstem compression due to rise in ICT. So the other thing is you get irregular respirations. So was he going into asynchrony also? Was it at any point here?
Sir, actually from day one, because of metabolic acidosis, he was having asynchrony requiring very high amount of fentanyl. We went up to almost 150 mics per hour of fentanyl. We're also giving propofol infusion in the range of almost 70 to 120 mg per hour. So still this point of time, asynchrony was quite prominent, sir, by this time. Still on these too high dose of sedatives.
So you have not shown me any CT. When he came to me, was there any CT MRI done now? He has come to the ICU or MRI. He was in the...
I have like both the CTs comparing together. I put in one slide, sir.
No, you just show the okay, you can show it later on. So what is the CT like and what is the X-ray like at this point? No, now he's in day 3, day 4, day 3.
Yes, sir.
The X-ray and CT like?
Just skip the slide and I will come to the X-ray and CT right now. Should I come to the slides?
No, you just tell what was there in the X-ray and CT. We can you will reveal everything otherwise.
Sir, the NCCT head which was done in the emergency, it was reported to be all the brain structures were reported to be normal, sir. There was some X-ray on admission is perfectly fine, sir. Chest X-ray was perfectly fine with no infiltrate or no consolidation and no blunting of CP angle as such.
Now, of course, there is some problem. There is some hypoxemia when he has come. So the X-ray was done in the this thing also in your casualty in your ICU also. That was also normal.
Yes, sir. On day 1, it is perfectly normal, sir. The X-ray.
Okay, carry on.
Although the ultrasound shows bilateral consolidations and infusions.
Yes.
Correct?
Minimal infusion, it was there, sir.
So no MRI was done, no CT chest was done.
CT chest was not done, sir. We have one normal contrast CT of brain on admission in ED and the chest X-ray.
No, I think they were not working on the brain part because he was always M6 to start with, and everything ventilation and rest of the things was going on for chest tissues.
Actually, when he got intubated, after that PF ratio that rose to some 300 or 350. So actively, the ultrasound finding were also okay. So, and X-ray was not suggestive of some like pleural effusions and some consolidation. But in ultrasound, there was some air bronchogram. Okay. So with improving chest condition, because of that, CT was not ordered. CT chest.
So, do you think a MRI would have helped? Because the radiology department, I think, is very close to the ICU in the ground floor itself. MRI to rule out encephalitis. Does it help in dengue encephalitis? Is there any feature of dengue encephalitis on MRI? Because there was a possibility he was drowsy. Could have been encephalitis. Shashikant, does MRI help in dengue encephalitis in any way?
I'm not sure about any specific finding related to dengue encephalitis on MRI of brain. But if you have to diagnose, we should get the serology, like it's NS1 or IgM or even the IgG in the CSF.
Very good. So that is absolutely true. The diagnosis of dengue encephalitis is from the CSF, IgM or PCR. There is no characteristic finding of dengue encephalitis on MRI, but nonetheless, to get certain changes which are compatible with encephalitis, it can help. Huh? So that is just a thought, because of course he's not really a candidate for dengue encephalitis, not a strong possibility with so much uremic encephalopathy going on. But nonetheless, sometimes patient present with dengue encephalitis, and we have to consider MRI and CSF. CSF is generally not practical, because the risk of bleed is there in all these patients. So dengue encephalitis is a difficult diagnosis, a diagnosis of exclusion we have to make in dengue patients. Okay, carry on, please.
So around this event, the pupils were still 2 mm in size, but the response has become sluggish from normal reacting. We did a ONSD and it was elevated on both the sides. And we did a transcranial Doppler, and based on formula, we calculated ICP, which was around 21 mm of Hg. So we increased the sedatives in terms of adding extra propofol to the infusion. We started hypersmolar therapy with 3% NS, and by this time, like patient was hyperventilating too much, and his PCO2 was around 14, and his total BICA was around 11. So we had to paralyze him to control his hyperventilation due to metabolic acid, because this much of hyperventilation and hypercapnia is not good for cerebral circulation. So,
No, so what is happening here in the ABG, Dr. Shashikant? You know, he has this PCO2.
Metabolic acidosis.
he's having metabolic acidosis and is hyperventilating to compensate for that metabolic acidosis.
So
No, is this primary hyperventilation or is this hyperventilation secondary to metabolic acidosis?
It was there since admission because of renal issue. He was having metabolic acidosis, but now this time it has worsened. So it could be added by the central hyperventilation also, sir, by this time. Because of this.
So why did you not control it with more sedation? You know, we should have tried to control this PCO2 of 14. This will lead to the constriction extreme and hypoxemia.
Yes, this time he did ABG and this showed the PCO2 of 14. Before that, it was above 25 and 26 only, sir, before this point of time.
No, in this HCO3 of 11.2, PCO of 14, and what is the pH here?
Just put the ABG. So this was the ABG at this point of time, sir, with pH of 7.43, PCO2 of 14, BICARB of 9.5.
So this is after he has gone into hypertension and bradycardia at this point.
Yes, sir. Yeah, this point of time, sir.
And this is after dialysis?
This is on day 2, sir. This is on day 2, sir. Dialysis happened one day before. Not
so this
on
is
the
after
scene.
one session of dialysis. He's having hypokalemia and he's in PA. So you would like to interpret the ABG? What is the diagnosis, ABG diagnosis after dialysis on controlled ventilation in renal failure?
Here he's having severe metabolic acidosis. Acidosis actually with a secondary respiratory response, and he's having hypokalemia and normal lactate. With oxygenation is around, with PF ratio is almost more than 300.
No. I think he's having a metabolic acidosis, clear cut, and a respiratory
alkalosis also, sir. Respiratory alkalosis too.
No, which is primary here? Is the alkalosis, metabolic alkalosis primary or respiratory acidosis primary?
Respiratory alkalosis.
Respiratory acid. It is metabolic acidemia, and that is primary.
No.
So,
how will we decide here whether acidosis pH is 7.43 towards the alkalotic side?
Yeah.
So how will we decide, Dr. Shashikant, whether this is a primary acidosis, whether this is primary respiratory alkalosis or metabolic acidosis?
That this change in pH we have to see with reference to change in PCO2 and this change in BICARB, sir. Like which component is, but as of now in this patient I'm not able to make with. For me, it looks more of metabolic acidosis with hyperventilation added. But if we have like two things going together, so we have to see the change in pH with respect to the change in which is contributing more, whether it's change in PCO2 which is contributing more, or whether it is response of metabolic acidosis which is more. So based on that, we can actually
see here. It is a little difficult to say because we have to have a prior ABG. One, because you are doing dialysis, he's on controlled ventilation, so it becomes a little difficult. So things are fluctuating. You cannot just take this ABG because he's obviously the metabolic milieu is changing. Here is on controlled ventilation.
Yes.
But if you have to take this ABG, any ABG, and both the values are deviated, then you have to see the percentage change in the value. That is the most important. So by percentage change, it means like you take the PCO2 of 40 and you take 14 by 40. So you see the percentage change, right? So that is 14 by 40. I think we will come to 1/3. So that is a 33%. PCO2 will become 33%, right, of the original. And you bicarbonate 10 of 24. 10 of 24 is 40%. So the PCO2 has changed much more. So the primary change here is in PCO2. So it becomes a primary respiratory problem. It's a respiratory alkalosis because the deviation in PCO2 is more than the deviation in bicarbonate. And then you try to apply the formula for compensation. But for that, you have to know the previous ABGs and everything. So the primary deviation in your PCO2 and HCO3 has to be taken into consideration when there is so much change and whichever is deviating more is the primary change.
So,
Such
like in this patient, the primary change was metabolic acidemia. Then he got intubated, and though he's on VCV, it is assist mode. So patient is obviously hyperventilating, which is leading to decrease in the carbon dioxide. It's kind of a mixed pattern of ABG abnormalities, maybe triple disorder here.
Sir, if that is true, that everything, that's what I'm saying, but just the ABG value. If the clinical condition, you are right, there is metabolic acidosis and there is respiratory alkalosis also. Now, the respiratory alkalosis, whether it's occurring because of brain edema or because of increased ventilator settings, we do not know. So, no ABG can be interpreted without the clinical scenario. But
yes,
just to look at the ABG, just for the students, if there is deviation in both the things to a great extent, then the percentage change is the primary change. And the secondary may be a part of the disease or maybe compensatory. And triple day, if you have to see the triple base disorder, then one has to look at the anion gap and all those things. So definitely you are right in those things. And ABG cannot be just put up and said what is there in the ABG. It becomes difficult.
Yes.
The clinical scenario, what is happening before, and a lot of things are happening. He's on controlled ventilation, dialysis is going on. He's already doses, like you have said. So definitely I agree with you. But just for the students, just looking at the ABG and if there are deviations, then how to make out. That is just what I was trying to say. And just
exactly.
Slide, you have done the ONS and all that, please.
So from day 3.
Before this, there was one slide, no? Yeah, before. Yes, so, Dr. Rahul sir, for the students, you would like to tell how to see the ONSD?
Okay. For optic nerve sheath diameter.
And TCD, how to TCD, I think you have put a video, you can tell then. So how will please tell the students how they should see the ONS?
So for optic nerve sheath diameter, first thing is patient should be sedative, well sedative. Patient is coughing, you can't get the data. Eye should be covered with the Tagaderm, transparent dressing. It is better. Apply lots of jelly. Take a linear probe with depth set to some 3 centimeter to 3.5 centimeter. Some high resolution linear probe should be taken. And if you don't have a ophthalmological setting, you can keep the setting to thyroid. Then try to see the posterior part of the globe. And towards the posterior part, there will be some black shadow, which is covered by some gray shadow. So that is optic nerve sheath. And to take the diameter, we have to take from gray to gray, because it's the extension of the brain, and it is from gray to gray, and that to 3 millimeter from the globe, posterior globe. That will give the exact site of optic nerve sheath diameter. If it is more than 5.4 in adult population, it is considered that ICP is high. And this, when we are taking optic nerve sheath diameter, one may put the color Doppler, because at times this artery may cause the optic nerve sheath diameter to be very high. So we have to rule that out.
So thank you for that, Dr. Rahul sir. So Dr. Rahul sir, correct me if I'm wrong. If the ICP is rising, the ONS will keep increasing immediately. Instantly.
Yes, immediate.
But if there's a decrease, then it does not decrease instantaneously. It takes a few days to decrease. That is also there. Am I right?
Yes, you're absolutely right.
Yes, okay. So now we have raised ICD, which has been documented with your ONSD and TCD, and you have given hyperosmolar therapy in 3% NS. So now it is important to control the raised ICD, because it is obvious it's going to Cushing's reflex. So how much of 3% have you given here, Dr. Shashikant?
This time we had given bolus of 100 ml, and we started around 10 to 15 ml per hour, like 10 to 15 milliequivalents 10 to 15 ml of 3% NS.
So did the Cushing's reflex respond to the hyperosmolar therapy? Did he settle down?
Sir, actually, after this, we did serial ONSD monitoring. It was still on a higher side only, sir. More than 6.5 or 7 bilaterally.
No, but what about the BP and bradycardia?
For some, transiently, it was like this fluctuation in heart rate and blood pressure that normalized for some time, sir.
So then how will you use hyperosmolar therapy here? If you give of a certain amount, that is okay. But what about the boluses? If it is not settling, would you not like to give a bolus every time there's hypertension and bradycardia occurring?
Actually, like the dosing, I'm not very sure like how frequently should be boluses of 3% MS. We normally start with one bolus, then we start with continuous infusion and titrating our monitoring of sodium, sir, targeting at least more than 155.
Yeah, the target is not more than 155. It is
150 to 155.
155. And can you use mannitol here? Why did you not use mannitol?
Already patient is having a deranged renal parameter, sir, with almost anuric to oliguric urine output. So giving mannitol will cause further renal injury. So we avoided giving mannitol here.
Can you use mannitol in renal failure?
If the like the osmolarity, if it is more than 320, it is not recommended to use mannitol.
That is true, but if the osmolarity is less than 320 and the patient has renal failure, and you cannot use 3%. Supposing the patient has congestive heart failure, he's poor ALEF, where 3% is contraindicated, and you have the option of giving mannitol, but the patient is renal failure. Can you use mannitol at all in renal failure? So you can use mannitol in renal failure provided you do dialysis within the next few hours, because mannitol is cleared by dialysis. So that is very important. And why you do not use it in renal failure is because, one, it will lead to increased intravascular volume, which will not be cleared by renal. And second, the circulating concentration of mannitol will increase and will lead to renal injury, like you said. So that is about mannitol and this thing. 3% HNS. Okay, carry on, please.
So the dose of 3%, what was the consensus? 3 ml per kg.
No, the dose for the 3% HNS depends on the HNS depends on the concentration that you are using. Whether you are using 3% or 7% or 23%. If you're using 23%, you give 30 ml. So that way the dose is varying depending. That's the concentration, more the dose. And you normally give boluses. So the boluses are guided by your signs of ICT. If the ICT is increasing, you give boluses. Infusions don't really help because you want to bring down the ICT immediately. And when you have evidence of high ICT, you give the bolus. So the ICT comes down, and then you monitor the patient. The ICT goes up again, then you bring it down. But that is not the way to actually treat raised ICT. You have to correct the primary cause. So the primary cause has to be seen, and there's a role for decompressive craniotomy also. Because once you are going into Cushing's reflex here, it's a very serious thing. Cushing's reflex is not to be taken lightly. So one has to see what is happening here, why the ICT has gone up, whether he has bled inside, or whether something else has happened, why the ICT has gone up, and there's a strong role for decompressive craniotomy in these patients with so much raised ICT. Infusion of 3% don't really help. Boluses is the way to go. Boluses of mannitol or boluses of 3%. And if 3% is not helping that much, then mannitol can have an additive effect. There is no clear-cut answer as to whether mannitol is better or 3% is better. So one has to try both, and sometimes patients respond better to one. So by their efficacy is the same, but there are differences in the mechanism of action. Mannitol acts as a osmotic diuretic, right? It increases the osmolarity of the intravascular volume, draws the fluid from the brain into the intravascular volume, and there's an osmotic diuresis. While 3%, when you give 3% or 23% or 7% hypertonic saline, again the serum osmolarity increases, it draws water. But the diuresis is not that much instantaneously. It mainly draws water, and there's an increase in the intravascular volume. So there's a difference in the slight difference in the mechanism of action. And there's a difference in the side effects also. So, and when to use, when not to use. For example, you will not use hypertonic saline in CHF patients. Well, mannitol can be used. And renal failure, you avoid mannitol, you can use 3%. So it's like that. Some differences are there. But at the end of the day, these are temporizing measures. One has to try and correct the cause. So let us see what is happening to the patient now.
Day 3 onwards, patient started mounting fever in the range of 100 to 101 degree Fahrenheit. We still continue to sedate and paralyze him because moment we stopped paralysis, patient was having a lot of agitation and lot of antitracing training. So we had to continue paralysis. His serial ONSD was still on higher side, more than 7 mm both the eyes. And still his BP was fluctuating with systolic between 150 to 175, diastolic 78 to 94, and heart rate between 50 to 75. Was still on control mode of ventilation, but by this time his effort was going up and PF ratio started worsening. And by this time the chest X-ray started having infiltrates more on the left side. And his urine output is still on the lower side, 5 to 15 ml per hour, and he received another session of dialysis on day 3 of ICU stay.
So here you see the coagulation is pretty good. In fact, it's improving, right? What is worsening is your lung. So what is happening in the lung, Dr. Shashikant?
His FI2 started going up, and also X-ray, serial X-ray showed bilateral chest infiltrate, sir. It was bilaterally, but more on the left side, in the lower zone, bilaterally.
So
probably he has got a new infection in terms of like ventilator-associated pneumonia by this time.
So this has developed in the ER itself because the TLC had gone up, and it has been dropping since then. So there was no initial infection, but you had noticed some shredding of pleural and all that. That could have been due to dengue, but definitely TLC had gone up. So maybe set in at that time he had come drowsy, had aspirated, or he has developed a VAP. So definitely there is a nosocomial infection or a VAP developing here, and that is the most likely reason. Any other reason why the hypoxemia is occurring? Are you giving a lot of fluids? How are the fluids being monitored?
Sir, we are restricting the fluid to almost 1.5 to 1.6 liter in 24 hours, sir. So we are restricting the fluid here because patient was having almost like just 150 to 200 ml urine in a day.
So fluids you're not giving too much. And what about any other cause for hypoxemia here? Considering that is a dengue patient and he is having some bleeding here and there.
Possibility, unless he bleeds into the lungs and he has like diffuse alveolar hemorrhage kind of
so
thing.
You cannot see on the X-ray whether he's got alveolar hemorrhage. He has been bleeding and he's severely uremic, like we have said. The coagulation parameters are improving, but he's very uremic. And what is, you have done how many sessions of dialysis on day 3 now?
This was the second session on day 3.
So has it improved the kidney function? Has it dropped the uremia?
Yeah, slightly, not much. Like from more than 300 to it just came to like 250 or 260 urea, create around 10. Yeah.
So there is not much of a difference. So you can see, and the degree of platelet dysfunction depends on the uremia. So there's significant uremia still, and that is why his bleeding could be having pulmonary hemorrhage also. Huh?
Maybe.
And what was the aspirate like? The ET aspirate, was there hemorrhage?
No, sir, never.
Okay. So generally you would get some bleeding in the ET aspirate if there is pulmonary hemorrhage. So not always, but most of the times you would get. So it's unlikely because the TLC was very important. The TLC had gone up in the ER itself. So most likely developing a secondary pneumonia, and it is decreasing. And I'm sure you must have ruled out there was no fluid overload like you are saying. And at the same time, his urine output is also decreased. Earlier it was 20-25 ml. So let us see now what is going on. And his ONST is increased, so ICT is increased. So here, Dr. Shashikant, his ICT is going on increasing. And was we able to do a CT or a MRI here?
Yeah, we got a CT done, sir. So I will just show the
CT scan.
So on the left, we have NCCT head on the day of admission, sir. It was reported to be perfectly normal. Actually, we can see this brain parenchyma and the ventricles and other structures, they look perfectly normal. But on the day 4, we had a CT that shows in the left side, in the parieto-occipital region, we can see infarct. It's actually hemorrhagic infarct. So we can see this infarct and with periregional edema, and also there is midline shift, sir. And also we can see the ventricles on the left side, they are effaced because of this bleed.
So this was done on day 4, right?
Yes, sir.
Okay, so this was reported as hemorrhagic infarct.
Yes, sir.
So why do you think infarct should occur here?
Actually, we are attributing it to related to one of the manifestations like expanded dengue syndrome. It is one of the CNS manifestation of EDS in reported to be reported in dengue, sir. So actually, this patient is not having significant thrombocytopenia or coagulopathy to attribute to this CNS bleed. But as per the literature, we can have, it's not just the absolute value of platelet count or the coagulation profile which predict the CNS bleed. The patient can have vasculopathy, even the platelet dysfunction. And actually, we are not monitoring the other parameters in this patient, like what is the fibrinogen level, whether it is hypofibrinogenemia, AIIMS. So
No. See here, the bleed has occurred mainly because of uremic dysfunction. And secondly, he's a dengue patient. Those parameters are not deranged. See, with the platelet count of more than 50,000, you do not get thrombocytopenic bleeding. One. With the INR of less than 1.5, you do not get a bleeding because of coagulopathy. And in this, fibrinogen does not come too much into account because here, the values correlate with INR and platelet. This is not a situation of liver disease where you have to use TEC. Huh? So
yes,
mainly because of uremia. And I'm sure you must have done dialysis without heparin because heparin,
yes,
so that is, there's no use of any low molecular weight heparin. So yeah, the component of dengue has led to the bleed. My question is, why is there an infarct this patient now? He should be bleeding, that we have explained. Why is there an infarct? So infarct will rise because of two conditions in dengue. It is well documented. One, there is vascular dehydration, or there is dehydration occurring anywhere. It is documented. So if the patient is intravascularly depleted, you can get infarcts. It is documented in literature. I have seen splenic infarcts and infarcts here and there. And the second reason is he's got dengue encephalitis. Dengue encephalitis can cause vasculitic infarcts.
So the question arises like it is approximately more than day 10 when this patient developed infarct. So encephalitis, if it is because of per se because of the complication of encephalitis, the time and the picture, it is not that common. Huh? It's one of the rare complications which struck the patient, isn't it, sir?
That is true, sir. The complications of dengue, you see, there's an initial phase of 3-4 days when there's fever, and there's a critical phase of the next 6-7 days when complications arise. Was at day 10 with altered sensorium. So there is a remote possibility. I'm not saying it is strong, but one has the infarcts. He's not intravascularly depleted. That is quite clear. Monitored him. You have seen the IVC. IVC is not even when he has come. And after that, I'm sure he never received so much of ultrafiltration that he got dehydrated. That must have been monitored. So the other possibility is there was some degree of encephalitis. Maybe it was not that much. I cannot say. Those are the only two reasons. Either there was a depletion, because dengue does not cause classical thrombosis that you are getting bleeding also and thrombosis. It would be very unusual. Of course, I see you can get bleeding and thrombosis both. And dengue causes a peculiar kind of coagulopathy. It is not classical DIC. So that is the only other thing, that he has got a peculiar kind of a vasculopathy which is causing both bleeding and thrombosis at the same site. That is highly unusual. I have not seen that. But what is documented, what I have seen, what is in literature is either there is intravascular depletion which leads to thrombosis in dengue and infarcts, or there is vasculitis because of dengue. And dengue and any kind of encephalitis in the brain can lead to vasculitic infarcts. Maybe there was not a florid encephalitis, there could have been some encephalitis. It's not possible to say. So just the explanation for that.
Yes,
so,
yes.
Any comments, or Dr. Raut sir, any comments? This is just a conjecture, just the explanation we can offer. We do not know. He has bled, that is clear, just the explanation for infarcts. So just go back now to your... So now you have this bleeding and your ICP is increased, your ONS is increasing, and he's getting surges of hypertension. So what kind of a therapy can we offer to this patient? What is the best therapy? I mean, can we get a neurosurgery consult here?
Yeah, we got a neurosurgery consultation here done, sir. So by this time, still INR was His INO was perfectly normal, but his platelet count were like less than 1 lakh. So we had multiple review by them, and by the time the decision of like going for surgical intervention in terms of decompressive craniotomy, by the time the patient did not survive, sir. So
Yeah,
we are optimizing the patient in terms of building his platelet counts more than 1 lakh. So
okay. So the decompressive craniotomy, Dr. Ritesh, any comments? Does it help? Does it not help in these patients who have refractory ICT rise? And should we go ahead? Any experience? Any comments?
So if it is a bleed and you do a decompression craniotomy early, it is helpful.
Okay. So Dr. Rahul sir, your experience, you are working in an advanced center, how frequent and how much you are using in these patients of raised ICT, different kind of settings you must be getting decompressive craniotomy, and you have to consult the neurosurgery colleagues.
So like as Dr. Ritesh is saying, it is indicated it will help, and it will help in better outcome. One may debate about the neurological outcome, but yes, it will help. The issue is like in this patient was having uremia and platelet count were less than 1 lakh. So for any neurosurgical process or procedure, platelet count has to be more than 1 lakh, and there should not be uremia. So they were suggesting that we correct platelet count and we correct uremia. So because of that, we lost some precious hours. Otherwise, like if we could have done it, who knows, patient could have survived.
Yes, I agree with that. Those things are always there. Surgeons want very good conditions, and the risk of all complications has to be avoided. But the platelet count is improving. I don't think there's a platelet count problem here. The problem here is when you do a decompressive craniotomy to relieve raised ICT, one, it has to be done in time. Here you already have brainstem involvement. By pushing reflex, and even on the CT, I can see the brainstem is distorted. So irreversible condition or deterioration should not have occurred. Otherwise, DC done in time has a good outcome, not only in terms of survival, but in terms of functional outcome. Many of these patients are walking around if it is done in time, and the condition is reversible and if it done in time. So we should push for DC in these patients where nothing much can be done. You can give your osmotherapy, you can do hyperventilation for some time, and you can manage the other things. But the underlying condition has to be treated. So that is very important. DC should be given prior consideration before irreversible damage has been done, and we should push. So, Dr. Shashikant, let us go back and to your slides. I think there were some slides remaining.
So on day 4, by this time his sensorium has dropped further to E2B2, and we got NCCT done, and with the finding we just now discussed. But still having fever spikes, we continued our anti-ICP measures. Still his ONSD were elevated on both the sides, and by this time his ICP on causality index formula-based calculation, it was 20 mm of Hg. By this time his BP was stabilized to, it's still fluctuating between 124 to 170, and diastolic between 90 to 105. The heart rate was around 90 to 108. And still his FI2 requirement on 60 to 70%, and FI to PF ratio was between like 150 to 200. His zero output further dropped to 0 to 5 ml per hour.
So, Dr. Shashikant, just going back there. Now the patient is obviously in ARDS, his bilateral infiltrates, and you have the definition and everything for ARDS. He has raised ICT. What are their recommendations, if any, for ventilating a ARDS patient with raised ICT? Are there any specific recommendations?
First thing, if ICP is raised, so proning for ARDS, that can further rise in ICP if you are not optimizing the positioning and all, not taking care of this. Actually, this patient position actually. So if still it is not like contraindicated, we should not go for it.
It is not an absolute contraindication.
Not absolute contraindicated. We can do. with slightly head up position, sir.
Okay. Any? Yes, sir.
PEEP, you cannot give high PEEP to these patients. If you are giving high PEEP, that can further increase your ICP. And I was wondering, like, do we have some ultrasound report of this time? Were there any increase in the B lines, bilateral distribution of B lines? Because this may be maybe some pulmonary edema secondary to brain insult.
Sir, as of now, there was no B lines. We have just like worsening consolidation bilaterally.
Okay.
So we did not have a B lines.
So the other thing is there any limitation to PEEP? Like sir has mentioned, PEEP should be kept low. Any recommendations about how much PEEP you can give in these patients? Is there any upper limit?
Sir, actually, as per the literature, PEEP less than 15 centimeter of water, they do not cause rise in ICP. So still up to 15 we can go.
No,
But
no,
after 15,
it is not like that. You are right. You can give up to 15.
yes,
The thing is, you have to maintain oxygenation. So whatever lowest pressures can be used, lowest PEEP, lowest airway pressures have to be used to maintain your saturation of PO2 82. And how much PO2 is recommended?
PO2 is 55 to 80, not more than that. Minimum 55 we can accept for ARDS patient.
But for brain injury,
it has to be high.
It is 80 to 110. Huh? Patients who are having brain injury, it is 80 to 110. And even for ARDS patients, the recommendation now have gone up a little. Huh? It is more than 92% in general. And you should avoid hyperoxemia and hypoxia. PO2 more than 120 should be avoided in all patients in ICU. Saturation of 100% should be avoided. So that because it leads to toxic oxygen radicals. We have a tendency and we are happy to saturation of 100%. That should be avoided. And brain injury patients or brain patients, PO2 is recommended 80 to 110, like Dr. Rahul sir has said. The other question is, he was having a lot of uremic bleed and of course dengue bleed. Is there any drug for uremic bleed?
Drugs which has been commonly used like desmopressin,
Yes.
the subcutaneous or nasal spray can be given.
Yes.
But again, the effect is not long sustained, sir. It is very for like just 2 to 3 days. The effect is sustained for 2 to 3 days, and it's not
So
very
we should
effective.
try desmopressin. Uremic bleed is highly recommended.
Yeah, as per the literature, we can try.
Yeah, as per the literature everywhere, we should try.
Yes,
Be available, but I think it is available in many places. So what is the dose for desmopressin? IV? It is
10
0.3
mics.
microgram per kg to be given over 15 minutes and to be repeated as required. So desmopressin we should give consideration because this is a very common scenario. Because we do not do platelet function in our ICUs or in our most of the hospitals. We do not quantify that. But uremic platelet dysfunction is very much there. It is happening here. It is very much there, but because we do not have a test for assessing platelet dysfunction, we do not give it that much importance. It just gets lost in the thrombocytopenia and the IPTT. Please carry on.
How about platelet transfusion?
If the patient is having platelet dysfunction, and if you transfuse platelets, again that transfused platelets they may not be sustained in circulation for a very long time.
No.
So
now I'm discussing indication of platelet transfusion in a dengue patient with intracranial bleed.
again, if the patient already have IC bleed, we should target platelet count of more than 1 lakh as per the guidelines. And without IC bleed, still we can allow up to 10,000 if the patient is not having any symptomatic bleed.
So did we transfuse platelets also there?
So after this IC bleed and this event, we started transfusing platelets to target at least platelet of 1 lakh. Sir. Okay. So he received like 4 to 6 RDP before he expired.
Okay, carry on. Anything else? Any more slides? Please finish the slides. So just show the ABG. I think there was some confusion. Now he's still on controlled ventilation, I believe.
Yes, sir, is still on control mode with increasing FiO2, sir, around 70% this by time.
So were
And,
you using paralytic agents also or just sedation?
By this time, we are able to stop paralysis, sir. When he had like raised ICP and we stopped paralysis, we continued on high dose of sedatives with fentanyl and propofol by this time.
Neuromuscular blockers you are using for how long? I mean, continuous infusion or bolus, or how are you using it?
Used for continuous infusion for almost 24 hours, sir. After that, we for one day we give just boluses, and next day we stopped it completely, sir.
So, Dr. Rahul sir, I would like you to tell our audience about the use of neuromuscular blockers in these neuro patients. Like, are they good? How much should we use, etc.? Any kind of guidelines or any comments you want to make?
So we don't see neurological patient that often because we are not a neurocritical center. But like in we see lots of patient of hepatic encephalopathy where ICP is raised. So like if there is asynchrony, lots of asynchrony, we can give relaxant boluses.
Yes.
But I'm not the best person because I'm not dealing with neurocritical.
Okay, I understand. That's okay because the neuro ICU. So, Dr. Ritesh, what do you think that they have any neuromuscular blockers in neuro patients, especially? Should we?
So, if there is a raised ICP, if there is an ARD accent.
Oh.
If you are tightly controlling the carbon dioxide levels, and then we have to use relaxant for that, then we use muscle relaxants.
So, are there any particular contraindications or side effects kind of things with neuromuscular blockers in neuro patients? I mean, generally, you should try to use with sedation. That's general guideline.
Yeah.
Blockers, if there's too much asynchrony, then we use. But any particular things related to these neuro patients, use of NMBS?
No, I'm not aware of that.
There are two things. One, it suppresses seizure activity, right? If you paralyze the patient, you won't know whether the patient getting seizures. The seizures are very important to pick up seizures. Second is these patients often have some kind of deficits, motor weakness, etc. And NMBS contribute or can prolong neuromuscular weakness. So just to tell you the two important things about neuromuscular blockers in neuro patients in particular, but as general guideline, we should avoid as much as possible use sedation. That is definitely there, and it pertains to neuromuscular to neurology patients also. So now coming to this ABG, Dr. Shikant, now please tell the diagnosis of this ABG.
He's having it looks more of respiratory alkalosis now because PCO2 is around 33 and this bicarb is slightly elevated. So it looks more of respiratory and he's having apart from it, his oxygenation is not good. His PF. Yes.
What is the ABG diagnosis, Dr. Shashikant? You may be asked.
It looks to me respiratory alkalosis with secondary metabolic response, sir.
No. Secondary metabolic response meaning what?
Bicarb is slightly high, sir.
So this is combined alkalosis.
Combined alkalosis.
This is combined alkalosis. The bicarb is increased. Normal bicarb is 24 for ABG.
Yes, sir.
Low. So this is a combined respiratory more than your metabolic, combined alkalosis. And of course, oxygen targets are good. It is 120. And sodium is good. Potassium is okay. And chloride is okay. Calcium is okay. Magnesium millimoles, I do not know what is the value. Sugars are kind of okay. Lactate is good. So by and large, everything else is kind of okay. That is the ABG. Carry on.
So this is the TCD recording, sir. We did when the patient has Cushing's reflex. So this was through the left temporal window, and we look at the velocities through left MCA. And based on the velocity, maximum, minimum, and also the mean, we calculate the pulse rate index, and we applied it to the formula to calculate the ICP, sir.
Okay. So, Dr. Rahul Kumar, sir, you like to tell the audience anything about this PI index?
No, actually, I haven't used TCD.
Okay. So, did you do the TCD, Dr. Shashikant?
One of my colleague did, sir. I did not do. One of my
Are you
colleague.
aware of the formula for calculating this?
Sir, for pulsatility index, it is the Vmax minus V minimum divided by mean velocity, sir.
Very
So
good.
average
That
of
is, yes, that is very
index.
good. So it is very good that you are using transcranial Doppler and 1S, because that is very good and leads to early detection and follow-up, because you cannot shift the patient all the time, but it has to result in clinical decision making and early decompressive craniotomy if the patient is not responding. So those things are very important. I think one question, Dr. Shashikant, we have increased ICT in 3 ways here, right? One, he is gone into Cushing's reflex. Second, you have done the ONSD, and then you have done this PI. Now, is there anything else you can do to pick up increasing ICT in a patient? You are on the rounds, this is neuro patient obtunded, and you are monitoring him. How else can you pick up increasing ICT? Now, daily the patient is lying, you go around seeing the patient, he's obtunded, GCS is on 6, 7, and you are not yet using your Dopplers and all that. How else will you pick up? Whether the patient is deteriorating in terms of raising ICT.
I think clinically we can look at the drop in GCS, sudden drop in GCS, one thing.
So
And
what exactly will you look in GCS? Everything is not ICT. Some features have to be there.
decorticate posturing.
Yes. So okay. So all those things have to be seen. Whether he's developing decorticate, decerebrate posturing, whether pupils are becoming asymmetric. These are we don't always do. When we go on the round, we don't always look at the pupils. Whether he's developing unilateral signs. So decerebrate, development of unilateral signs, change in respiration pattern. Respiration pattern, stereotic breathing, steroic breathing, all these things point to increasing ICT. And here you had a very clear-cut sign of Cushing's reflex. That was very important. So once you have Cushing's reflex, it means the patient is really deteriorating. So I request Dr. Rahul Kumar sir to make the comments, what he has to say now about the case. Any comments, sir?
Okay, so the last comment is like in this patient, there was some complication which is not very common in dengue patient. It was some IC bleed. And like in this IC bleed, the golden hour approach of DC could have done something. That's it.
Okay. So, Dr. Ritesh, sir, your comments, final comments, anything you want to add, anything?
Yeah, so I think he rightly said that we were able to diagnose that by day 2. We should when we were strongly thinking that the ICP is becoming refractory, we should have tried decompression with that. As far as the incidence of raised incidence of intracranial bleed with dengue, this is less. But yes, now slowly cases are being reported with that. We had a case of large intracranial frontal bleed in a dengue patient. Of course, there was another predisposing factor where the patient had some degree of chronic liver disease. So there also that situation was there. But now few cases are being reported with IC bleed.
Okay, thank you, Dr. Ritesh, sir. So, Dr. Shashikant, sir, one of the questions to you, you have done very nicely, presented very nicely. Thank you so much. The question to you is just stop the share screen. You have to stop the share screen. It is not stopped yet.
You take it to the top, and then there would be a drop-down menu.
Okay, so Dr. Shashikant, the question I want to ask you, just two questions. Why do you think the patient had renal failure? Was it intravascular volume depletion, or was it something else, or what was it? He had very significant renal failure.
This patient, we have meta-diagnosis, it was a dengue. So in dengue, we can have AKI because of various reasons. It can be prerenal because of capillary leak and intravascular volume depletion. Secondly, it can be immune complex mediated glomerulonephritis. Another, we can have acute tubular necrosis. And also these patients can have significant myositis and rhabdomyolysis. So this can also
Excellent,
cause.
excellent, excellent. Very good. So, but this patient was not pre-renal because his volume status was not like that. Blood pressure was 190, so I don't think it was pre-renal. Now, the last question to you is, you see, you must have seen dengue. We all see dengue. It is so common. Dengue can cause practically all kind of complications. You know that, huh? You have seen hepatitis and syphilitis. What complication it does not cause? Can't hear you.
I don't know, sir.
Okay. So any comments from anyone, sir, Rahul sir or Ritesh sir? What complication does dengue not cause? It causes so many complications. But if you can have seen anything like that.
So it can lead to almost everything, right? From
ARDS,
joint pains.
ARDS is uncommon.
Huh?
Oh, I have seen ARDS because of it.
With dengue. ARDS is uncommon with dengue.
No, ARDS occurs because of capillary leak, because of infection. Encephalitis occurs, hepatitis occurs, myositis,
So secondly,
acute renal failure occurs. What does not occur is arthritis. Huh? Dengue does not cause arthritis. It causes arthralgia, some joint pains, but it never causes arthritis. So that is something which is very interesting. Practically all other complications. It can cause myositis, vasculitis, thrombosis, as we have seen, infarcts, everything. But arthritis as such, it does not cause. Joint pains, myalgias, arthralgias, yes. So
Yes.
unusual and interesting.
I have seen MI because of it in a pregnant lady.
Yes, so it causes, definitely, sir, it causes myocarditis. It can cause some degree of vasculitis sometimes, but myocarditis and MI can occur. So it causes everything. And that is all. So, Rahul sir, thank you very much for making this possible from one of our premier institutes, All India Institute of Medical Sciences. And I thank Dr. Shashikant sir. He has done it very nicely and he has answered very well. All the best for his future. And thank you, Ritesh, for your valuable contribution. Thank you very much.
Thank you, sir.
Thank you so much, sir.
Thanks, everybody. It was a wonderful interactive session. Thanks a lot.
Thank you.